be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.
Good evening, everyone. Welcome to tonight's Lung Cancer Living Room. Thank you all for joining us, everyone in the room, those of you watching live online, and those of you who are going to come back and watch post-live. We're very excited to have all of you here tonight, as well as Dr. Joel Neal, who a lot of you know, I am sure, coming to us from Stanford. This is his second time speaking at the living room, Anyway, we're really excited to have him here tonight. We're doing a little sort of flip, but not switch, on tonight's meeting. It was originally going to be, as you guys all know, and saw through all the communications, an immunotherapy today. But given that we are literally on the heels of the World Conference on Lung Cancer that just finished up over the last few days in Barcelona, we're going to add a couple of things to that. So we're still going to have a primary focus on immunotherapy and what's happening today, but we're going to add in a couple of other little things. Before I ask Dr. Neal to introduce himself, I should introduce myself, which I should have done at the beginning of the evening. But for those of you who don't know, I am Danielle Hicks, and I oversee patient support services for GoTo Foundation. Prior to that, I was Bonnie's daughter. And only her daughter. No, I'm teasing. Lung cancer entered my life in 2003 when she was diagnosed, and we joke all the time that it's not even about her anymore. It's come so much further, and never in my life would I have ever imagined that I would be doing something like this all these years after her diagnosis. But I wake up every day and I love going to work, and I love watching all of the exciting things that are happening, and I'm grateful that Dr. Neal's here to talk to us about some of those things tonight. Bonnie needs no introduction. Everybody knows who she is. She walks into a room, people are like, she's like famous. I'm like, really? No, I'm teasing. She is kind of famous. So I'm going to ask Dr. Neal before we break in tonight to just, not like he needs an introduction. Everybody in the room pretty much introduced him, probably way better than anyone else can. But tell us who you are, why lung cancer matters to you, and then we'll jump into tonight's.
And why you do what you do.
Yeah. Well, first of all, I'm grateful to be here, and also astounded at the stories that were shared. I think my shoes grew about 10 sizes, and now I have to fill back into them by the end of the evening.
So no pressure.
You know, there are other great lung cancer doctors out there. The other patients just didn't mention their doctors' names or the institutions. Like, there's a lot of places you can get incredible care around the Bay Area and in Northern California and everywhere in the world. So I'm a thoracic medical oncologist, on paper. I've been at Stanford back now 9 years at this point. I say back because I've shared this fact with a few of my patients. I was actually born at Stanford way back when. So I'm a native Bay Area product.
Wow.
Went far away to college down to San Diego in the UC system to get away from my parents. And then out for MD PhD at Northwestern in Chicago, and then out to the Harvard system, where everybody has to be from Boston at least once in their life, right?
Right.
And now I consider Boston a great place to be from, being a Californian,
Yeah,
you know, with all due
right,
respect to everybody else who's done the lung
right,
cancer
right.
living room here.
Right.
And I really enjoy what I do with the mix of patient care, a couple of clinics a week, running clinical trials, working with our incredible basic scientists on campus at Stanford, in Northern California, and everywhere in the world. But why do I do this? Well, I guess I'll share a story that I don't think I've shared with my patients and probably haven't shared, you know, with many. But when I was 10, and 10, around age 10, it's a very formative time, right? You know, you're coming out of childhood, you're starting to actually pay attention to the world. My grandfather was diagnosed with colon cancer, and he got one round of chemotherapy and moved straight to hospice shortly after that. And I remember spending a very short time, you know, in and out of a couple of clinic visits and spending time with him. And I felt like it was just really, really fast and really unexpected for all of us. And I don't know if I even mentioned this story when I was writing my admissions essays to college or medical school or grad school or internship or fellowship or all of those things that I had to go through to train. But I always kind of wanted to do oncology and wanted to do cancer, but also cancer research. And my hardest decision was, which side do I do? Do I do the research side and go into a lab and really work on those basic problems, or do I treat patients? And it's amazing that I get the privilege of actually doing both of those things, as well as connecting with people incredibly deeply. And the stories that I hear and the bonding is unbelievable. I could never have envisioned how rewarding it is, at least for me. And sitting here hearing all the stories, you know, if I'm ever feeling down, I'm going to let you know, and you can invite me back to do another one of these things.
Yeah, for PTSD.
But I really do feel like you know, this is a living room, and when I think about my own family's living room, it's a place that family comes together. And for me, this is not only feeling surrounded by family, but almost a family reunion here. Mm-hmm. So thank you.
And being a researcher and running a clinic is the perfect storm, and the perfect good storm. Because if you're just a researcher and you've never met a patient, you know, you're focused, but the end result is different than when you're in a clinic and actually doing research too.
Yeah, I always felt like the research was nice, but if we can tell a patient, hey, we're designing this right now and we want to bring this in for you, right, it's even better. Right, exactly. And I will say kind things about Boston too. It's where I got steered.
Because Posse's online.
Into Posse's everywhere all the time. He's certainly omniscient. But you know, that's the people that I worked with at Mass General Hospital and Dana-Farber, like, discovered EGFR mutations while I was there. Discovered ALK and figured out how to test for it. I heard the story when I was a fellow of this 20-year-old guy who was on a clinical trial of this drug called PF0012341066. And I'm like, okay, well, you know, it might be hard to remember that license plate name, but it was working. And this tumor was melting away on a phase 1 clinical trial, which is usually our expectation is, well, we'll see what the side effects are, and then we can see whether it's effective once we get up to the higher doses. But that drug became crizotinib. And so all of these key stories, and I said, well, if there's 2 huge stories in lung cancer, how many more are there? I couldn't in my wildest dreams have envisioned immunotherapy being successful, and we'll talk about that and touch on that tonight. And the combinations and the number of things in our tool set and the number of new molecular alterations that we're figuring out, effective therapies that are well tolerated too, it's an unbelievable time to be privileged to be in this field.
You want to talk a little bit about lung cancer?
Can I just throw something in just to end what you said,
Mm-hmm.
because you're so absolutely correct. Lung cancer is almost 30% of all cancer. So if you look at that 30% that represents all cancer, if we knock it down 30%, look what happens to all cancer. You know, I mean, it's reduced in a huge number, and that means lower cost of healthcare. I mean, it means so many good things. And you know, and Dr. Neal's going to talk about this. We've got KRAS and small cell and a few other things that we have to work on, and we've got all these other mutations that we're working on. But we are headed in the right direction, and if you throw screening in that, which is, a huge percent of lung cancer, if caught early, we can address it and get to a chronically managed disease. That's huge. That's absolutely huge. What's happening right now in research is huge.
Well, yeah. So
No pressure.
no doubt screening is absolutely important, and Danielle, I'm sure you've heard and discussed the word scanxiety in this forum once or twice before, and we know even our patients, our survivors who have had 27 scans in the past, there's something about going and getting the scan and then having that result somewhere available and then coming back and discussing it. It's very anxiety provoking, and I have to say it's probably like back in the days I'd take the SAT or something. I'm like, what's my score, right? But it's in a very personal, very, very life-threatening way, potentially. So that's absolutely real. The screening scans, the interesting thing about them is the only populations that have been screened are people who have a smoking history. Active smokers, people with a history of smoking, ages actually a limit of age 55 up to 80 is where the current guidelines are here. And hearing around the room, I would suspect if we took a poll, many of the people here didn't have a smoking history. Many of the people here. To eliminate smoking-associated lung cancer seems like an easier problem overall. And if we talk about screening, I think that's an interim solution to reducing the exposure in the first place. Ideally, over the long term, if we could say, hey, everybody quits today, then suddenly 30 years from now, lung cancer is 10 to 20% of the incidence of what it is with those naturally occurring, not great, but sporadic, random, truly have no explanation lung cancers that aren't associated with smoking. But since we have smoking as part of our population and people smoke, and I always like to point out, like, if you go to tobacco.stanford.edu, it's a fantastic website. It's a website that shows all of the marketing information spread by tobacco companies all the way back to the 1910s that show how the companies made us smoke as a population, right? That and if you show people this was done because somebody kind of forced you to do it, then they have a realization like, oh, it's not my choice, and people like to have choices, and they don't do it anymore. So tobacco.stanford.edu is a great place to go spend a little bit of time. Things like 40,000 doctors at the American Medical Association meeting in the 1930s chose this brand of cigarettes over this brand, right? And like those sorts, and they would hand out free packs of cigarettes at all the American Medical Association meetings. Like it's so. I think first and most importantly, like working on the exposures that we have control over, screen everybody who's eligible, absolutely. Then we can find early stage lung cancers and get to where kind of my vision is for 10 to 20 years from now, which is we're going to be running the kinds of clinical trials that the breast cancer groups have been running for decades, where we need 10,000 patients to participate so that we can find these little tiny differences in cure rates, right?
Yeah.
But screening for lung cancer or any cancer shouldn't be an accident.
It shouldn't be. Everybody
we shouldn't
who's
be finding lung cancer by accident. We should be proactive about finding it early, and everybody should get a screen if they want one, because anybody can get a mammogram and anybody can get a colonoscopy. The only thing that cuts people out is the age group. To be able to do that. But we have to work on that. And we're hoping that the FDA is going to approve this. It's already happening in Europe.
That's great. I want to just pause. Michelle, do you have anything online? Anybody want to say anything? Okay, I just want to make sure. I want to
the whole world is quiet.
Yeah, right. I'm sure.
They want to hear about what's working.
Yeah, I want to jump a little bit into PD1, PD-L1, tumor mutation burden. What's relevant? When is IO right for a patient? What's going on right now with immunotherapy?
All right, so just
jump
lung
in.
cancer 101. Let's
Right.
do it. Well,
Let's do it.
yeah, maybe we'll start off on this idea first, kind of go through by stage, right?
Sure.
And so if we're fortunate to detect lung nodules when they're early stage 1, which is basically in the lung, stage 2, which is generally a little bigger tumor or moved to a lymph node in the center of the chest, but still in the lung, not between the two lungs. Or stage 3, which is lymph nodes in between the two lungs or fairly large tumors, then our primary goal is to cure those cancers, right? Our primary hope is always to cure every single lung cancer that we find, but we're not sure how to define it in terms of stage 4 patients who are living long time with treatment. So stage 1, we think surgery or maybe radiation. Often we don't do molecular testing on those tumors because the chance is high of getting rid of those. For stage 2, again, surgically resection, often with chemotherapy afterward. Still the most solid data to cure an additional population of patients after surgery for stage 2 and some stage 3 lung cancers is 3 months of chemotherapy after surgery. Sometimes chemotherapy before surgery, but chemotherapy is where all of the data are. And with all of the hype about targeted therapies and individualized therapy and immunotherapy and everything else, the data are for cisplatin is preferred, 4 cycles, 3 months. It's not fun, but as Tina said, it's an insurance policy is how I describe it to patients in the adjuvant setting. So chemotherapy is still the mainstay of early stage treatment. For stage 3, we often incorporate radiation, and sometimes for stage 1 and 2. Still, again, no clear role for the targeted therapies in that. But for stage 3 with chemo plus radiation, there has emerged a role for immune therapy. Regardless of PD-L1, regardless of testing, it's fine to do the testing. And if we know molecular status, that affects our probability of it working a little bit, but we still often offer it to everybody. And a year's worth of immune therapy with a drug called durvalumab after chemotherapy plus radiation improves cure rates in stage 3. So that's kind of the early stage non-small cell lung cancer overall approaches. But then with stage 4, when a patient's diagnosed and unfortunately it's already spread outside of those boundaries of radiation where we can try to get it all in one radiatable field or with surgery, then we say, how do we maximize, first and most foremost, quality of life? You gotta live well. With or without cancer, our primary focus should be on our quality of life, right? Not saying like my 5-year-old does, which is I want a lollipop every 5 minutes. Like that's not maximizing quality of life, right? But
Well,
like,
it is his.
it's maximizing his.
Yeah.
Made mine worse that I ever showed him what a lollipop was ever, right?
Because he's up for 48 hours.
But like, focus on quality of life, both decisions now for the long term to make your quality of life better in the long term, but also like, how do I have fun right now too? And balance those two things. That's what life is about with or without cancer. And if we're living better, we're gonna live longer too. That's just part of it. So how do we live better? Well, we give the most effective therapy first, and one hopefully with the fewest side effects in balance to that first. So that's the concept of personalized therapy and why testing is so important for non-small cell lung cancer. And the testing that we recommend for every patient, newly diagnosed, adeno or squamous, first they have to figure out what flavor it is. So I describe those as the flavors. Adeno is more gland-like, squamous is more skin-like, and those are the major subcategories. Sometimes there are neuroendocrine ones too that go in a little into the small cell direction. But for adenocarcinoma, PD-L1 testing, that takes a day or two generally. That's almost part of the diagnosis. EGFR mutation testing. Absolutely critical. That can take a week or two and is worth waiting for. ALK testing, ROS1 testing, and generally BRAF testing. Those are less and less likely that I listed in order. So EGFR mutations in the US, 15% of patients. And for people who haven't smoked, up to 50% chance. ALK, 4 to 8% depending on the population. ROS1 and BRAF about 1%, very, very much lower. But those are the 4 targets that we have that are these switches that turn on and off, that we have drugs that work better than chemotherapy in the frontline setting, better than immunotherapy in the frontline setting, and are generally better tolerated also. So we want to give those first and say, let's wait on chemotherapy and immune therapy till later. So it's important to get all the molecular testing, at least with kind of that core set. And other testing can be done for later. Then if those are negative, then we say, well, what's the best treatment overall, at least for adenocarcinoma? We say, well, chemotherapy was good. There are trials that said adding immunotherapy is better. And chemo plus immunotherapy is the standard of care. But for patients whose tumors have high PD-L1, so that's, I describe PD-L1 because I know many of the patients know the lingo. I'm super impressed by everybody, by the way. Know the lingo, but sometimes I say, well, okay, how do I explain this to simplify it? PD-L1, I think of it like a shield on the outside of the tumor. So basically, the tumor, from whenever we couldn't detect it and it was very small, may have been growing over time. And the immune system may have put pressure on that tumor and tried to fight it. PD-L1 was the shield defense against the immune system that some tumors evolved to basically say, go away, immune system, you have to shut down. The immune system plays by the rules. It's part of our normal systems. So the tumor can grow shielded from the immune system at that point. PD-L1, when it's really high, suggests that there's more shield. And then if we give an antibody to PD-L1 or the detector for that, which is PD-1 on the other side, that breaks down that shield, and then the immune system can come in and do the job that it was trying to do. This is not creating an immune response. This isn't coming up with something out of nowhere. It's relieving that block that the immune system was blocked from doing. So it doesn't work for every single patient, but we do know for patients whose tumors have high PD-L1, it's a lot more likely to work. Even more likely than chemotherapy by itself. So sometimes we give immune therapy by itself, save chemo for later. Squamous, very similarly, chemo and sometimes immunotherapy, and with immunotherapy or immunotherapy by itself. But if patients have history of autoimmune problems or other things, or high risk from chemo or high risk from immune therapy, of course we want to make it tolerable together. And surprisingly, it is for most people relatively well tolerated to try that combination of chemo and immune therapy. So that's the US standard of care right now. So I know other countries are other ways.
Yeah. Some people are talking about chemotherapy and saying it's not your grandfather's chemo, because we have so many great drugs now that'll keep you from being nauseous and getting sick and all of those things, that forget all of those things you learned or watched on movies, where people were on chemotherapy and immediately started going downhill. That's really not the case.
That really was my grandfather.
Yeah, exactly.
I really saw that.
Exactly.
He felt rotten the entire time and said, I never want this anymore.
That's what's in everyone's thought process, and it doesn't have to be that way.
So I assume when patients come and they're hearing about chemotherapy that they're going to hear what they had from TV or whatever their friends of a friend had experiences with chemo, which usually wasn't the first chemo that person ever got that they're hearing about.
Yeah.
So I assume, hair loss, not as often as you might think, nausea, vomiting, usually more constipation now because of all the drugs that we're giving to prevent the nausea, vomiting, and slow everything down.
Right, exactly.
And, low blood counts, not as much, like hospitalizations, not usually. Like quality of life's pretty good, and we have patients that work for the most part, in between cycles of chemotherapy.
And gaining weight instead of losing weight.
Exactly.
Right,
as we've stopped the tumor from growing, oftentimes people say, I feel better now.
Right, exactly.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. and it could be just you and me. We'll be family. Just wait and see.